Picture this. It's a cold winter night in 1348, and screams echo through a manor house as a young woman fights for her life. She's been in labor for 18 hours, and everyone knows that sunrise might bring either a healthy baby or two more graves in the churchyard. There are no hospitals, no anesthesia, no emergency surgery, just a circle of women, a collection of herbs, and centuries of accumulated knowledge about guiding new life into a dangerous world. How did they do it? How did medieval women survive an experience that killed 1 in 3 mothers and claimed half of all babies before their first birthday? The answer lies in a sophisticated network of female expertise that operated largely outside official medical knowledge. While university-trained physicians studied ancient texts and debated theoretical humors, midwives learned through hands-on experience, oral tradition, and the brutal reality that their reputation depended on keeping mothers and babies alive. They developed techniques that were often more effective than anything taught in medical schools, creating a parallel healthcare system that saved countless lives. Medieval childbirth began long before labor started, with an elaborate preparation process that could span months. Experienced mothers and midwives understood that survival depended on careful planning, physical preparation, and assembling the right support network. As soon as pregnancy was confirmed, usually around the 4th month when movement could be felt, the community of women began organizing for the birth. The first critical decision involved choosing a midwife. In wealthy households, this meant hiring a master midwife with years of experience and a reputation for successful deliveries. These professional birth attendants commanded high fees and often traveled significant distances to assist noble families. They brought their own supplies, including specialized herbs, birthing stools, and emergency instruments that could mean the difference between life and death. For common families, midwife selection depended on local availability and personal relationships. Village midwives were usually older women who had successfully raised their own children and learned birth assistance through apprenticeship to experienced practitioners. They worked for payment in goods, services, or small amounts of money, and their success rate determined their standing in the community. But here's where medieval birth preparation gets truly fascinating. Midwives didn't work alone. They operated within networks of female knowledge that included herbalists, wet nurses, and experienced mothers who each contributed specialized skills to the birthing process. These women shared information about herbs that strengthened contractions, techniques for repositioning babies in difficult presentations, and emergency procedures that could save lives when standard methods failed. The herbal arsenal available to medieval midwives was surprisingly sophisticated. Ergot, a fungus that grows on rye, was used to strengthen contractions and control bleeding after delivery. Pennyroyal and tansy helped expel the placenta. Chamomile and lavender provided pain relief and calming effects. Willow bark contained natural aspirin for fever reduction. These weren't folk remedies, but effective medicines that modern science has validated. Skilled midwives understood dosages, timing, and drug interactions that could enhance or complicate treatment. They knew that ergot given too early could trap the baby and cause uterine rupture, but administered at the right moment could save a woman bleeding to death. They recognized signs of infection, understood how to position laboring women to ease delivery, and possessed emergency techniques for handling breech births, twins, and other complications. Medieval people understood that successful childbirth required more than medical intervention. They created elaborate social rituals that provided emotional support, practical assistance, and spiritual protection for laboring mothers. The lying-in period began several weeks before the expected birth, when pregnant women withdrew from normal activities and entered a female-centered world focused entirely on preparing for delivery. During lying-in, experienced women shared birth stories, taught breathing techniques, and provided emotional preparation for the ordeal ahead. They helped arrange the birthing chamber, assembled necessary supplies, and coordinated the support network that would assist during labor. This wasn't just social gathering, but systematic preparation that addressed both physical and psychological aspects of childbirth. The birthing chamber itself was carefully designed to maximize safety and comfort within medieval limitations. Windows were covered to prevent harmful drafts and evil influences. Fires were kept burning to provide warmth and hot water. Birthing stools, chairs, or beds were positioned to allow midwives easy access while giving laboring women support and mobility. Religious objects, Protective charms and family heirlooms created a sacred space that provided spiritual comfort. When labor began, the support network activated with military precision. Messengers summoned the midwife and assistant women. Servants prepared hot water, clean linens, and herbal preparations. Family members began prayers and arranged for emergency supplies that might be needed if complications developed. The laboring woman entered a world where her needs became the absolute priority of everyone present. Medieval midwives possessed sophisticated knowledge about normal labor progression and warning signs that indicated developing problems. They knew that first babies typically took longer than subsequent children, that certain positions could speed or slow delivery, and that specific symptoms warned of dangerous complications. They monitored pulse, breathing, and skin color to assess the mother's condition throughout the process. The most critical midwifery skill involved manual techniques for assisting difficult deliveries. Experienced practitioners could reposition babies presenting incorrectly, manually remove retained placentas, and perform emergency procedures that saved lives when standard delivery became impossible. These techniques required years of training, steady nerves, and the trust of families who literally placed their lives in the midwife's hands. But here's where class differences created stark inequalities in survival chances. Wealthy women had access to the most skilled midwives, the finest herbs, and elaborate support networks that could sustain them through prolonged labor. They labored in heated chambers with clean linens, abundant food, and multiple attendants focused solely on their care. They could afford the best medicines and had backup options when primary treatments failed. Poor women faced childbirth with minimal support and limited resources. Village midwives might assist multiple women simultaneously during busy periods. Herbal medicines were expensive and often adulterated with cheaper substitutes. Laboring women might lack adequate nutrition, proper shelter, or even basic privacy during delivery. Many poor mothers returned to heavy labor within days of giving birth, increasing their risk of complications and death. Rural peasant women developed their own survival strategies, adapted to harsh economic realities. They formed cooperative networks where experienced mothers assisted younger women during labor, sharing knowledge and providing practical help without formal training. They used locally available herbs and developed techniques for managing birth complications using household materials and improvised tools. Urban artisan families often had better access to professional midwives and medical supplies, but they faced different risks from overcrowded living conditions, polluted water, and higher disease exposure. City midwives served larger populations and developed specialized knowledge about urban health challenges, but they also charged higher fees and might not be available during busy periods. Medieval religious beliefs profoundly shaped birthing practices in ways that both helped and hindered survival. The Church taught that childbirth pain was divine punishment for Eve's sin, discouraging the use of pain relief methods that might interfere with God's will. However, religious institutions also provided sanctuary for unwed mothers, established charitable hospitals for the poor, and created networks of female religious communities that preserved medical knowledge. Prayers, religious relics, and spiritual rituals formed an essential part of medieval birth assistance. Laboring women wore protective amulets, called upon patron saints for assistance, and received blessings from priests or religious women. These practices provided psychological comfort and community support that helped women endure prolonged labor and recover from difficult deliveries. Some religious orders specialized in caring for pregnant women and new mothers. Convents maintained herb gardens, operated charitable hospitals, and trained nuns in midwifery techniques. These religious institutions preserved medical texts, documented successful treatments, and provided continuity of care that individual practitioners couldn't match. However, religious restrictions also limited certain treatments and created conflicts between spiritual and medical approaches to birth assistance. The most dangerous complications required emergency interventions that tested the limits of medieval medical knowledge. Prolonged labor, excessive bleeding, and infection were the leading causes of maternal death, while babies died from birth injuries, breathing problems, and congenital defects that couldn't be treated with available techniques. Skilled midwives developed emergency protocols for handling these crises. They knew techniques for manually extracting babies when normal delivery failed, methods for controlling hemorrhage using pressure and herbal medicines, and procedures for reviving newborns who weren't breathing. They understood when to continue trying to save both mother and child, and when to focus on saving the life that had the best chance of survival. The most controversial medieval practice involved embryotomy, the surgical dismemberment of dead babies to save the mother's life. This procedure required specialized instruments, surgical skill, and the emotional strength to perform devastating operations on grieving families. Only the most experienced midwives attempted embryotomy, and the decision to proceed often determined whether communities viewed them as lifesavers or butchers. Infection was perhaps the greatest killer of medieval mothers, but its causes weren't understood in terms of modern germ theory. Midwives developed empirical practices that reduced infection risk without understanding the scientific principles involved. They emphasized cleanliness, used herbal antiseptics, and recognized symptoms that warned of developing blood poisoning. The most successful midwives insisted on washing hands, using clean instruments, and maintaining sanitary conditions in birthing chambers. They prescribed herbal preparations that modern research has shown to possess genuine antibiotic properties. They isolated women showing signs of infection and developed treatment protocols that saved lives even when they couldn't explain why their methods worked. Medieval communities understood that successful childbirth required support systems that extended far beyond the moment of delivery. The lying-in period continued for weeks after birth, during which new mothers remained secluded while recovering their strength and establishing nursing. Female relatives and neighbors provided practical assistance, emotional support, and childcare help that enabled recovery and bonding. Wet nursing became a sophisticated industry that saved babies whose mothers couldn't nurse and supported families when maternal death occurred. Professional wet nurses underwent health examinations, followed dietary restrictions, and sometimes lived in their employers' households for extended periods. They provided not just nutrition but emotional comfort for babies who had lost their mothers during childbirth. The guild system extended to midwifery in larger cities, where practitioners organized to control training, maintain professional standards, and protect their economic interests. Midwife guilds established apprenticeship programs, created licensing requirements, and developed ethical codes that governed professional conduct. They maintained libraries of medical knowledge, standardized treatment protocols, and provided mutual support during difficult cases. Guild midwives faced examination by experienced practitioners, demonstrated competency in normal and emergency procedures, and swore oaths to maintain professional secrecy and provide care regardless of patients' social status. They paid fees to maintain membership, participated in continuing education, and faced disciplinary action for negligence or misconduct. But even the most skilled medieval birth attendants sometimes failed, and communities developed coping mechanisms for dealing with maternal and infant mortality. Funeral rituals, memorial practices, and support networks helped families process grief and continue functioning despite devastating losses. Surviving children were often raised by extended family members, and widowed fathers typically remarried quickly to provide maternal care for existing children. Medieval birthing practices created the foundation for modern obstetric care, even though the underlying science was completely different. The emphasis on skilled birth attendants, systematic preparation, and emergency intervention protocols evolved directly into contemporary medical practice. The recognition that successful childbirth required both technical expertise and emotional support remains central to modern birthing philosophy. Most importantly, medieval women proved that survival in dangerous circumstances depends on knowledge sharing, community cooperation, and the determination to preserve life despite limited resources. They created healthcare systems that functioned effectively without formal medical training, government support, or scientific understanding of disease processes. The networks of female expertise that supported medieval childbirth established patterns of mutual assistance and professional development that continue to influence modern healthcare delivery. The integration of practical skills, emotional support, and spiritual comfort that characterized medieval midwifery remains relevant for contemporary birth assistance. So how did medieval women give birth without dying? They created sophisticated support systems based on accumulated experience, community cooperation, and the recognition that bringing new life into the world required the best efforts of entire communities. They developed medical techniques that were often more effective than officially sanctioned treatments, and they provided emotional and spiritual support that helped women endure one of life's most challenging experiences. The next time you marvel at modern medical technology or take hospital care for granted, Remember the medieval midwife who guided countless women through childbirth, using nothing but skill, herbs, and the determination to preserve life. They saved mothers and babies not because they had access to advanced technology, but because they understood that survival depends on knowledge, preparation, and the unwavering commitment to support each other through life's most dangerous moments. If you enjoy the hidden sides of medieval life, hit subscribe and give this video a like.